for having me today. Very, very excited to be here. Today, I'm going to be talking about fertility preservation for young adult cancer patients and survivors, and just very, very honored to be kind of part of the treatment for these really, really special patients. What I love about, what I do in this capacity is that preserving fertility is all about sort of next steps and about the next chapter of our lives after going through challenging treatment courses and a really challenging chapter. So I can't wait to share all of this information with you today. Thank you to Dr. Cooperberg and Shu for the really, really warm welcome. As they mentioned, I'm a reproductive endocrinologist and infertility specialist at USC, as well as the director of Oncofertility and our assistant fellowship program director. So I feel really lucky to be housed within USC Fertility. And also I'm based at a particular fertility clinic. It's called HRC Fertility, Huntington Reproductive Center here in Pasadena. So associated with both organizations. And really for all of our patients, on the call, I'd really love to see you in clinic to discuss kind of your individual circumstances more fully. And I'm available for either virtual or in-person visits. For all of our patients with new cancer diagnoses and our survivors, we're more than happy to offer you complimentary consultation just regardless of whatever insurance you have or you don't have. So I never want anybody to kind of feel that that might be a barrier. So please feel free to kind of message me here if you're on the talk today, or you can always email me at this address, katherine.mcdaniel@med.usc.edu, if you'd ever like to connect individually. And I'd really love for this to be an active session. I'll try and monitor the chat as much as possible, but please feel free to interrupt me at any point in time with any questions at all. I'd also like to give a shout out to my colleague, Dr. Manuel, who's also joining me from USC HRC Fertility here. So we're happy to have her on the call too. So today, the first thing that I'd like to do is review normal reproductive anatomy and fertility to talk about the major parts of our reproductive system and what we need to conceive. I also want to discuss the specific impact of cancer treatment on fertility, and this is really going to be highly dependent upon the type of cancer we have and the specific type of treatment we have. So, but I'll definitely do my best to provide you with some general information. And then I really want to go over in detail the different methods of fertility preservation and treatment. So in terms of normal fertility, what's really important to kind of keep in mind is that almost surprisingly, fertile couples only have about a 20% chance of conceiving every month. And really, this is because most of the time we're only releasing one egg from our ovaries at a time. We have different species, like rabbits, for instance, that are releasing many, many eggs from their ovaries every month. We're only releasing one. So that really limits our ability to have very, very high conception rates every month. That being said, though, by after 3 months, about 57% of couples will achieve a pregnancy. By 6 months, about 72% of couples will conceive. And by about 1 year, 85% of couples will be pregnant. So important to kind of keep these overall odds in mind. In terms of what we need to conceive, there's a few really, really important parts. So the first is our ovary. As I mentioned before, ovaries, their main job is to release at least one egg every month. Sometimes we might release more than one, but typically one egg. These eggs grow in structures called follicles, which are contained within our ovary. The next really important part of our reproductive system are fallopian tubes. These carry eggs from the ovary towards the uterus. Most of the time, egg and sperm meet in the fallopian tube. When egg and sperm meets, fertilization can occur. After that, an embryo can form. Typically, it takes about 5 days for an embryo to travel down the fallopian tube to reach the uterus, where the embryo will implant in the uterine lining. And if we want to be pregnant, hopefully it will grow after that. So the uterus also plays a really important role to house, to grow, to nourish a developing pregnancy. And then, of course, we need our male genetic information, which comes in the form of a spermatozoa, so which we see right here. That sperm grows and develops in a structure called the testicle and the testis, which is in the male scrotum. So, as reproductive endocrinologists, these are the parts of the body that we're really sort of focused on understanding in detail. There are some patients who come to us because they have been unable to conceive after a period of time. Generally, we recommend evaluation at 12 or more months in patients that are under the age of 35. For patients over the age of 35, they meet a definition of infertility if they've been trying to conceive for 6 or more months. So, as we age, it gets harder and harder to conceive on our own. So, we really want to have any patients over the age of 35 come and see us right away. There are also certain patients who we want to have come see us as soon as possible because we know that conceiving will likely be a challenge for them. And so these definitely are patients with a history of cancer diagnoses. And we'll go through kind of all of this in a lot more detail. But there are several elements of treatment for cancer that can threaten our ability to conceive and threaten our fertility. And so these are any cancers that require surgery on our reproductive organs. Also, any patients that have received chemotherapy or radiation to the pelvis. Apart from our cancer survivors, we have a number of other patients who are at high risk for infertility. Those are patients with a history of a condition called endometriosis, where we have the lining of the uterus developing outside of the cavity. Patients with a history of pelvic inflammatory disease, which is often can be caused by gonorrhea or chlamydia, or those with past uterine surgery. So certainly if you're a cancer survivor and you have any of these other complicating conditions, we highly, highly recommend that you come see us sooner rather than later so we can kind of figure out where you are. Um, I mentioned, and Dr. Cooperberg and Chu mentioned my title as Director of Oncofertility at USC. And so, just to explain a little bit, oncofertility is a specific sort of medical field that really works to maximize the reproductive potential of cancer patients and cancer survivors. We know that there are a number of cancers that are being diagnosed at earlier and earlier ages. So the number of reproductive age cancer patients that we have is definitely increasing, and we really want to do everything that we can to maximize the care that we provide you. We work very closely with our oncologists throughout the community to coordinate care. As you can imagine, in the setting of a new cancer diagnosis, we're all trying to work as expeditiously as possible to not delay any element of treatment. And so that requires us to work very, very closely with your oncology teams, which we're absolutely delighted to. Oncofertility is really important, for a whole host of reasons. And so, number one is I'll explain in subsequent slides. The chance of achieving pregnancy, unfortunately, is reduced for many male and female cancer survivors. Understandably, concern about fertility is then very common across patients of childbearing age with cancer. And we really, really want patients to come to see us regardless of, when their cancer might have been diagnosed, when they're planning treatment, or might have already had treatment, because we know that patients with cancer who undergo counseling with our teams have lower rates of regret, regardless of what direction they might move in. Also, very importantly, the American Society for Clinical Oncology does consider fertility preservation to be medically necessary for those undergoing cancer treatment. There are a number of different risk factors that can contribute to infertility after cancer treatment, and they're very specific to each type of cancer and the type of treatment that each patient has received. So biggest factors that influence fertility rates after cancer are the type of treatment, and I'll go into this. Did a patient receive surgery, chemotherapy, radiation? What was the dose of the treatment? How long did the cancer treatment last? How old was the patient at the time of treatment? Generally, our patients who are younger at the time of cancer treatments kind of fare a little bit better in terms of fertility. What is the patient's baseline gonadal reserve? I'll explain this a little bit more. So, our gonads are our ovaries in the case of our female patients, and our testes in our cases of male patients. So, we each have a certain number of eggs, or a certain number of sperm that we have in our testes. In women, our ovarian reserve declines over time. So, whether or not a woman suffers from infertility after cancer treatment is dependent upon the number of eggs that she has in her ovaries at the time of treatment. And another really, really important factor is whether or not a patient underwent fertility preservation prior to starting treatment. And there are a number of different ways to preserve fertility, and I'll walk through all of those in detail. So our sort of three, primary mainstays of cancer treatment include surgery, chemotherapy, and radiation. And what I'm going to do next is walk through the impact of each of these on different parts of our reproductive anatomy. So if we go back, to our image that we looked at before of the uterus, ovaries, fallopian tubes, and our spermatozoa, looking at the ovary. So the ovary can be impacted in a variety of ways by our cancer treatment. So did our did our patient have surgery on their ovary? We see a number of patients with a history of ovarian cancer, and so often times these patients require removal of one or both ovaries. Without the ovaries, we can't make eggs, which contain our genetic information, and we don't have any structures then that can be fertilized by the sperm to form embryos. Chemotherapy can definitely have a huge impact on ovarian function. There's a class of chemotherapy agents called alkylating agents that can definitely have significant damage on the ovary. Then also dose and duration of chemotherapy can have a big impact. Also, radiation can have a huge impact on the function of the ovary. So there are several types of cancer. For instance, are cervical cancers that can require radiation to the pelvis. And when the ovaries remain in the pelvis, then we can definitely see impacts from the radiation. Moving on to our fallopian tubes, luckily our fallopian tube function isn't impacted as much by chemotherapy because our fallopian tubes don't have rapidly dividing cells. But fallopian tubes can definitely be impacted by surgery. There's a number of ovarian cancers, which require removal of the ovaries at the same time the fallopian tubes might be removed. Also, radiation can impact fallopian tube function as well. The uterus can be impacted by surgery. So, our endometrial cancer patients, oftentimes, in cases of quickly moving cancers, will have their uteruses removed. Also, radiation can impact uterine function. And very lastly, are the function of our sperm, the function of our testes can be impacted by both surgery or all three: surgery, chemotherapy, and radiation. Moving on, I'm really kind of going to drill down into each of these parts of the reproductive system in a little bit more detail. And also just really briefly wanted to share a document with everybody called the Fertility Preservation in People with Cancer Guideline Update. So this was actually published this year. So we're really, really lucky to have this update so newly available to all of this, published by the American Society for Clinical Oncology. And it provides a really, really great framework for how we need to approach fertility preservation for all of these different parts of the reproductive anatomy. So really key recommendations is that patients with cancer should be evaluated for and counseled about reproductive risks at the time of diagnosis. And so this can come, through a variety of conversations with different providers. So certainly a patient's oncologist, and of course we love to see patients come to visit us in clinic when they're interested in speaking with a reproductive endocrinologist. So any patients who are interested in or uncertain about family planning should come see a reproductive specialist such as myself and Dr. Manuel. And different family planning approaches should be discussed prior to all forms of cancer-directed therapy. So I'm going to walk through a variety of different fertility preservation methods. Also really important to note for, those patients that can't produce eggs, after cancer treatment, those who can't produce sperm after treatment. We have a number of different approaches. We can help to match you with an egg donor, for instance, or help to match you with a sperm donor as needed. And then other, really important aspect of care for all patients is that family planning should be offered post-treatment to all of those who did not complete preservation prior to cancer-directed therapy. So we love to see you kind of at all stages of your care and are always available, to help in whatever way we can. Specific guidelines and recommendations for females is that so we have a few more established methods of ovarian fertility preservation that I'll drill down in detail, and these include egg freezing, embryo freezing, ovarian tissue cryopreservation, which is where we save large pieces of ovarian tissue. Ovarian transposition, where we move the ovaries outside of the pelvis, as well as conservative gynecologic surgery. So this is keeping those key structures in place as much as possible, including the ovaries, fallopian tube, and uterus. And again, ASCO really does recommend post-treatment fertility preservation for those who didn't have an opportunity to pursue treatment, fertility preservation prior to their cancer therapies. And for males, freezing of sperm should definitely be offered to all patients before cancer-directed treatment. And then if if a patient is unable to provide a semen sample, we do have other methods that we can use to remove sperm from the testicles prior to starting treatment. So these are really the key elements of the updated ASCO 2025 guidelines. Gonna drill down on sort of the fallopian tubes in a little bit greater detail right now. So, as I mentioned before, the fallopian tubes provide a very important function in that they transport an egg from the ovary to the uterus. And this shows all of the different parts of the fallopian tube. As I mentioned, surgery can really impact fallopian tube function because one or more fallopian tubes may be removed. Also, in patients who still have their fallopian tubes intact, if they undergo radiation to the pelvis, fibrosis, so this formation of scar tissue and adhesions can really impact the ability of the fallopian tube to move eggs towards the uterus. A few things that we can do to protect the fallopian tubes are going to be adopting a more conservative surgical approach, and definitely your oncologist would be the best person who's primed to let you know if this is an option. Your oncologist could decide that it's okay in the short term to leave one or both fallopian tubes in place until sort of reproduction is complete. Another option when we need to use radiation to the pelvis is to do whatever we can to minimize radiation exposure, and your radiation oncologist would definitely be employing the best approach to minimize the radiation exposure. Different techniques, include using different types of shields or sort of like lead protective devices and using the lowest possible doses of radiation. Important to keep in mind that if you need to have your fallopian tubes removed or you have radiation to your pelvis while your fallopian tubes are in place, we do have a technique to bypass the fallopian tubes, and that is, in vitro fertilization, where we stimulate the ovaries to grow eggs. We fertilize those eggs with sperm to make an embryo, and then transport the embryo back into the uterus. And so this helps us to bypass the fallopian tubes completely. So if you don't have function of your fallopian tubes, we definitely have ways to help you conceive. Now turning to the uterus. So the uterus plays a really, really important role in growing, supporting, developing, nourishing a growing pregnancy. As I mentioned before, different forms of cancer treatment can have a big impact on the uterus, mainly surgery and radiation. So with surgery, some forms of cancer require removal of the uterus. And so these are primarily our endometrial cancers, where we have cancer growing on the lining of the uterus. There are some conservative treatments for uterine cancer, such as an IUD, that allows us to spare the uterus and to save the uterus until we are ready for childbearing. Also, as I mentioned before, definitely radiation can have an impact on uterine function. It can result in reduced uterine volume, fibrosis, and vascular damage. And so, our radiation oncologists definitely do whatever they can to utilize shielding of the uterus and use the lowest possible doses of radiation when we're concerned about the reproductive function of the uterus afterwards. Um, so similarly to our fallopian tubes, if we need to remove the uterus because of cancer treatment, we do have other techniques that are available to help us have a child. This can be a really expensive and hard route, but in our patients without a uterus, a surrogate can be used to conceive a pregnancy. Also, in more limited locations in the United States, uterine transplant is available, but not currently offered anywhere in Los Angeles or California. Moving on to the production of sperm. So, as we mentioned, sperm grow, nourished, and are developed in the testicles and within a specialized region of the male scrotum called the epididymis. Um, we definitely recommend sperm cryopreservation or testicular extraction prior to initiating cancer treatment if possible, because not only can surgery, chemotherapy, and radiation, they can all impact the function of sperm. So when we have cancers that can impact, the testicles, such as testicular cancer, sometimes it's possible to leave one testicle in place until childbearing is complete. In terms of specific strategies to limit damage by chemotherapy, oncologists can select, agents that offer or present less toxicity to the developing sperm, as well as limit the dose and duration of chemotherapy. And the testicles can be shielded by our radiation oncologists as needed. And then always important to keep in mind that if any of these techniques are unsuccessful, sperm donors or embryo donors can be used to help a patient conceive. Moving on now to probably what is sort of the most complex part of fertility preservation, I'd say, is the ovary. So the ovary is exquisitely sensitive to aging. And so when we're thinking about cancer treatments and cancer therapies, as a result, we are very, very concerned about ovarian function and the impact that the treatments might have on the ovary. So I just wanted to share a few sort of slides just about ovarian function in general across all patients. So this very detailed drawing shows the life cycle of an ovary in a single month. So kind of on the left side of the screen, it shows us what our ovaries, the status is kind of at the beginning of a menstrual cycle. We have waves and waves of follicles that start to grow and develop at the start of each menstrual cycle. Ultimately, only one of these eggs is selected to continue to grow in a structure called a follicle. And in women with regular 28-day cycles, this egg is released around cycle day 14, of course, provided we're not on any birth control or anything to prevent ovulation. Once the egg is released, the follicle becomes a structure called a corpus luteum. So we have about 1,000 follicles disappear actually every month. Only one of those is ovulated. Unfortunately, our ovaries are susceptible to significant levels of reproductive aging. And this is very, very different from the male anatomy. So our testicle and our sperm aren't affected by similar degrees of aging. We continue to produce large numbers of sperm, in the absence of, any fertility threatening therapy, well into our 40s, 50s, 60s, and 70s. But unfortunately, as women, we're born with the maximum number of eggs that we're ever going to have, and that number declines irreversibly until we reach the age of menopause. So when we're thinking about females going through cancer treatment, we're definitely very, very concerned that cancer treatment might significantly impact the function, of our ovary, an organ that's already aging significantly, kind of on its own. The other thing that's really important about ovarian function is that, unfortunately, the number of genetically normal eggs declines significantly as we age. So by about age 30, 20% of our eggs are genetically abnormal. By about age 35, that's about 35%. And by age 40, that's about 60% of eggs that are genetically abnormal. So we sort of have two hits sort of being presented to ovarian function. Is number one, we're losing total numbers of eggs as we age, and those eggs are also more likely to be genetically abnormal. And so then, and bear with me as we go through this graph, keeping in mind that the ovary is already aging, if we then expose the ovary to both and or chemotherapy and or radiation, it can have a huge hit on ovarian function. So this graph sort of represents, we see on the left-hand axis the number of follicles or egg precursors we have in our ovaries. And here on the x-axis, we see our age. So similar to the other graph I showed, unfortunately, the number of eggs, the number of follicles irreversibly declines until we reach the age of menopause. Our sort of optimal fertility range is in our late teens going into our early 30s. After the age of 30, even without cancer treatment, our fertility is declining. As we enter our early to mid 40s, we start to have irregular menstrual cycles. And around that time, it becomes very, very hard to conceive on our own. Um, what makes chemotherapy and radiation so tough in terms of ovarian function is that we were already, seeing a decline in the number of eggs and follicles that we have, but chemotherapy and radiation can really have a huge negative impact on these numbers. And so you might see someone who was, headed towards menopause at the average age 51, but suppose they underwent chemotherapy and or radiation treatment around the age of 30, we might see that patient suddenly become at risk for premature menopause, premature ovarian failure, and a rapid decline in fertility. So, for that reason, when we're thinking about our female patients undergoing cancer treatment, we want to do whatever we can possible to help preserve their fertility because we might not have a return to fertility after completing cancer therapy. So there's a number of different protective strategies that we can use for the ovaries. So I've already sort of mentioned this idea of conservative surgery. So we completely understand in some circumstances we need to remove the reproductive organs, including the ovary. But if we can do anything at all possible to save an ovary or both ovaries, this is important to consider. The other thing too, I just wanted to make people aware of is we do have techniques that are primarily being used in Europe, but now increasingly adopted in the US, where we can actually remove a whole ovary and freeze the entire ovary in small pieces. And that can be transplanted back into the body at a later date. That's called ovarian tissue cryopreservation and is the second box here. Primarily, this is offered to patients who can't freeze eggs or who can't freeze embryos prior to undergoing cancer treatment. And these might be our patients who haven't yet undergone puberty, so we actually can't make eggs for them, including, infants. Infants now in some centers throughout the world are undergoing ovarian tissue cryopreservation. Other options that your oncologist may or may not have talked to you about already, or you might have even had yourself, is something called ovarian suppression. That's where we use really, really strong medications that talk to your brain to shut down the activity of the ovary. There's hopes that when we do that, if we prevent those follicles and those eggs from developing, that might shield them from some of the effects of chemotherapy. Another option, another protective strategy, and we use this, more commonly in our patients with gynecologic cancers, is something called ovarian transposition. And this is where, working with our gynecologic surgeons, we actually move the ovaries outside of the pelvis into the abdomen. Then this allows for pelvic radiation to be directed towards, any cancer cells in the pelvis, and hopefully sparing the ovary as much as possible from the effects of pelvic radiation. And really, our two sort of biggest mainstays of treatment and the options that we like to offer all patients, if possible, prior to beginning cancer therapies, is egg freezing. Also, another option is to fertilize the eggs with sperm and freeze embryos. This isn't possible in all patients prior to cancer therapies. So we definitely love to help patients, who are in the survivorship stage as well pursue these options, just because they are going to be at greater risk for premature ovarian failure, with many types of cancer therapies. What's really important to keep in mind is if, we try our very, very hardest and we can't preserve ovarian function, many patients can pursue options like egg and embryo donation. So I want to go through the egg and embryo freezing process in a little bit more detail to tell you what it looks like. What's really important to keep in mind is that egg and embryo freezing really is the first part of IVF. It involves about a 2-week ovarian stimulation process, and this is where we prescribe 2 to 3 medications per night. These medications are done at home by the patient after extended sort of teaching and training in our clinic. Our goal there is to grow as many eggs and follicles as possible. After about 2 weeks, we're ready to retrieve the eggs. We do that in our surgery center here. It takes about 20 or 30 minutes to do so. We do it under anesthesia. And then if a patient has elected for egg freezing, the process sort of ends at this point in time. In the future, if a patient wants to use their eggs, we would thaw the eggs, fertilize them with sperm, grow them into embryos, and then we could transplant them into the uterus at this point in time if the patient still has their uterus. If they don't still have their uterus, we could always explore the option of transferring an embryo into a surrogate. So that's a little bit about egg freezing. Embryo freezing is very, very similar, except what we do is immediately after egg retrieval, we fertilize the eggs and then we freeze them. Then they remain frozen and stored here for future use whenever a patient would like to pursue conceiving. What's really important to keep in mind is that there's definitely, some big major differences between egg freezing and embryo freezing. Fortunately, in some cases, patients don't have a partner, and so there wouldn't be a sperm source identified at the time that they're looking into fertility preservation. So egg freezing doesn't require sperm, but embryo freezing does. Another really important thing to keep in mind is that eggs generally survive a thaw less successfully than embryos. About 90% of eggs survive a thaw in the future versus about 98% of embryos. The time required for both processes is about 2 weeks. We also like to say that with embryo freezing, we get a lot more information about the developmental capacity of an egg. Before we go to fertilize an egg with sperm, we don't really know much about it. We don't know, how likely it is for the egg to be fertilized, how likely it is to be able to form an embryo. So with embryo freezing, that gives us a little bit more information about how likely the egg is to go on and form a successful pregnancy. Important to keep in mind that with egg freezing, there's lower upfront costs because we're not fertilizing the egg, we're not making embryos. However, in order to use the eggs in future, you would need, their patient would need to ultimately figure out how they might afford to fertilize the eggs to make embryos. And then the other really important thing to note is that with egg freezing, we can't perform genetic testing because we only have one set of DNA in the egg. But with embryo freezing, we can actually biopsy the embryo and perform genetic testing. And so this can be really, really useful for our patients who might have heritable cancer syndromes. things like BRCA, and they might want to test their embryos to make sure that they're not passing along a gene that can cause cancer in the future in their offspring. One thing I just want everybody to be super aware of, and I'm sure many of you already are, is our Senate Bill 600. And this is legislation that was passed in California in 2019. And this was a really, really important piece of work because it required that insurance must cover standard fertility preservation in patients with a new cancer diagnosis. In a new cancer diagnosis undergoing treatments that may directly or indirectly cause iatrogenic infertility. So this includes surgery, chemotherapy, and radiation. We do have a number of patients that we see in clinic that are routinely covered by this legislation, but unfortunately, there are a good number of exclusions. These include Medi-Cal plans, self-insured plans, plans that might be based out of state. It's really, really tough to get coverage under SB 600 once a patient has already had cancer treatment. So if at all possible, we love to see patients beforehand. And then also really important to note that SB 600 only really covers egg and sperm freezing. It doesn't cover fertilization of the eggs to make embryos. We have a good number of cancer patients that come in that might be BRCA positive, who want to test their embryos right away. And unfortunately, SB 600 doesn't cover that aspect of their care. Unfortunately, out-of-pocket costs can be significant, for both egg freezing and embryo freezing. Sperm freezing is a lot less costly because a man can easily produce multiple semen samples that can then be stored. For sperm freezing, the primary out-of-pocket costs are going to just be paying for sperm storage, typically on an annual basis. But with egg freezing, we have many more sort of steps to get the eggs. We need to have you take specialized medications, undergo ovarian monitoring. There's also fees associated with our surgery center, laboratory fees, and storage costs. But I just want to reassure everybody that we will do whatever we can to make this a financial possibility for you. Even if you don't have SB 600, we have a variety of different medication programs and discounts that we will employ to make this as financially possible for you as we can. The fertility medication companies, including EMD Serrano and Ferring Pharmaceuticals, actually have specific programs for patients with new cancer diagnoses. And so just showing screenshots from websites here. So this is the Ferring Heartbeat program here. Also, there are many clinics throughout the country, including ours, that offer significant discounts through the Livestrong Foundation. So we offer discounts of 25% for kind of all of our fees here. Also as well, one important thing to think about is storage costs for your eggs or embryos or sperm. So we do have a number of storage fertilities. We do have a number of storage facilities that offer significant discounts for patients with cancer diagnoses. This is an example of one here called Verna's Purse. And so we can see really, really significantly sort of discounted storage rates through these programs. Those are sort of the main topics that, I wanted to cover. I really, really just want to emphasize that every single person's clinical situation is very, very different. And I'd really love to work with you to understand more kind of about your current fertility status and to understand if there's any role for fertility preservation, either before starting your cancer treatment or if you've already had your cancer treatment. So please reach out if there's any way we can help. And I'd love to take any questions that anybody has at this point in time.